right, so we'll get started. Hey there, welcome to our channel at MerusGastro and Gut Health. I am your host, Dr. Sumanamoolemd, with our practice here in Johns Creek, Georgia. Today we have our guest, Dr. Rebecca Berens, who is a family practice specialist. And our topic today is going to be eating disorders and related GI disturbances or gut symptoms in that subset. Before we begin, I will talk a little bit about who Dr. Berens is and a little bit about her background. She is based in Houston. She's a wife, mother of two, board-certified family physician, and also an international board-certified lactation consultant. She's originally from Scotland, moved to Houston during her childhood, and then attended Rice University. That's amazing. And Baylor College of Medicine. Later on, she went on to do her residency in family medicine at Georgetown University and Providence Hospital in Washington, D.C. Currently, she is the owner of Vida Family Medicine, a direct primary care practice that provides affordable, accessible, and personalized care to families in the Houston area. So here, welcome, Dr. Berens.
Yeah, thank you so much for having me.
That's great to have you. Thank you for being here. So we're just going to chat about eating disorders, which is kind of a nice, unique, a subset that we could potentially, add value to our patients by educating them in whatever way we can, answer some questions. So yeah, thank you for doing that. So first off, how did you get involved in this subset of disorders, eating disorders? Could you elaborate on what those may be to our patients and how you got involved and an overview of what that looks like in your practice?
Yeah, absolutely. So I'm a family medicine physician. I'm definitely not like a psychiatrist or an adolescent medicine specialist, which is typically who people think of as treating eating disorders. And the majority of patients that I treat are people who have recovered from an eating disorder or have had some disordered eating behaviors, but never quite met full diagnostic criteria for an eating disorder, or people who maybe have binge eating disorder and they're not engaging in actively life-threatening behaviors in that moment. And so I got involved in caring for these patients through my own personal experience. I had an eating disorder when I was in college. And in my process of recovering from that, I learned about the health at every size framework and intuitive eating. And that really informed my practice of medicine from medical school on. And as a result, I've connected with a lot of great professionals in the eating disorder community who are dietitians, therapists, other eating disorder clinicians that are treating eating disorders. And so I've ended up building those relationships and getting patients referred to me who are looking for a healthcare provider that is understanding of the recovery process from an eating disorder and a safe place for them to go, because a lot of these patients do experience a lot of trauma or stigma from the healthcare system as a result of their experiences.
Mm-hmm. Yeah, no, that's really nice that your practice is open to treating this subset, because it's really rare to find subspecialists who are not psychiatrists to give a somewhat of a holistic, integrative, wholesome approach to their these disorders. Could you perhaps elaborate on what the most common eating disorders you see and what exactly their symptoms may be?
Yeah, so when I look at eating disorders, there's a lot of different DSM diagnoses and specific criteria, but I sort of break them into three main buckets: the restrictive type, the purging type, and the binging type. And you can have in any of the diagnostic categories all of these behaviors. So just because I think there's a lot of stereotyping, like people with anorexia are underweight and restrict their intake. People with bulimia are normal weight and may binge and purge. And then people with binge eating disorder just binge and don't purge. But typically I see a lot of these behaviors crossing a lot of the diagnostic categories. So I sort of look at those symptoms like restrictive behaviors, deliberately restricting intake, whether that's entire food groups, overall calories, or specific textures even. That can be one symptom type. And the most common one of those that we think of is anorexia nervosa, which is usually characterized by that significant restriction in intake and then often weight loss. But there can be cases where the weight loss is not as obvious, or the person may still be considered a normal weight or even in a higher BMI category and still can have anorexia nervosa. Then you have bulimia, which often includes periods of binging followed by purging, whether that's using induced vomiting or laxatives or other medications like diuretics to try to compensate for the binge. But often there is restriction between periods of binging. And then binge eating disorder typically involves binging, which would be eating a larger than normal amount of food, usually past the point of to feeling physically uncomfortable, or even like nauseous or like the need to vomit, and in a very short span of time. Often they have restriction between binges, but they usually do not purge. So to meet criteria for binge eating disorder, you would not be engaging in any purging activities. And then other compensatory behaviors that you may see in any of these categories would be like over-exercising. That's something that we see a lot, trying to compensate for intake.
Mm-hmm. So when they first come to your practice, say, I'm assuming they're not really in a crisis mode. They had gone through it. Now they're looking to get better and find a physician who understands this and guides them in the right direction. What would be their most common symptoms that you encounter at this time, and how do you direct them at that point?
Yeah. So yeah, most of the patients that I'm seeing, they've maybe been through, whether it's intensive outpatient, partial hospitalization, or residential, or even hospital level care, and have sort of recovered from the acute, active, most life-threatening stage of their eating disorder, but are having some ongoing complications, or just, need general primary care like every person does. So that's a lot of the patients that I'm seeing. I do see a lot of people with binge eating disorder that have not been diagnosed before, because that one is commonly missed and not commonly diagnosed. And it's not so acutely life-threatening for people to really notice that it's happening, for other healthcare providers to see it. So sometimes I am the first person diagnosing a person with binge eating disorder. But in general, there are a few symptoms that I see commonly in the GI realm amongst these patients. And the first really common one that I would say is constipation. People who have been restricting their caloric intake for a long period of time, your body compensates for that by slowing your metabolic rate. And one of the ways that it does that is by slowing movement through the gut. And so a lot of people who are been restricting their intake, even if it doesn't meet, technical diagnostic criteria for eating disorder, even just the chronic dieter or the fad dieter, can experience constipation. There's also a lot of overlap with IBS. So a lot of people who are experiencing anxiety, depression, other comorbid psychiatric conditions that often come with eating disorders also have IBS symptoms, because there is that mind-gut connection of the nervous system. And so a lot of those psychiatric conditions can exhibit symptoms in the gut that often is constipation as well. So that's a super common one that I see. Another really common one that I'll see is reflux. So like you would see like heartburn or gastroesophageal reflux disease. I see a lot of that predominantly, I would say, in people with binge eating disorder or who've been inducing vomiting, because there is that sort of not damage, but the sphincter between the stomach and the esophagus is impacted by inducing vomiting over and over and over again, and may not be functioning as well as normal. Or if there's been recurrent episodes of binging, there can be like increased pressure on that sphincter. And I do see a lot of those patients complaining of reflux type of symptoms. Then other common ones that I'll see, things like feeling cold easily, feeling lightheaded or dizzy, not necessarily GI symptoms, but can kind of combined with those GI symptoms, maybe point you in the direction that there might be something nutritional going on.
Do you look for nutritional deficiencies in these patients? Do you check labs to see what's going on and supplement? Do you find like one more common nutritional deficiency than the other?
Yeah, so it's actually interesting. The labs are not always normal. Are not always abnormal. And this is actually something that a lot of people who are struggling with an eating disorder, it's hard sometimes to help them understand how serious the condition is, because the labs can look normal. So if you go to like a regular PCP's office and have your labs done and you're in the normal BMI category, chances are the PCP is never going to ask you any questions about this, and just assume that you're doing fine from a nutritional standpoint. Now, we do see nutritional deficiencies, certainly in the long term. The first things that we usually will see are the slowing of the metabolic rate. You may see bradycardia or slow heart rate. You may see constipation. You may see cold intolerance. And then as it progresses, you may start seeing evidence of hormone disruption. So hypothalamic suppression, loss of menses in a female, and depressed thyroid function, those sorts of things. And then in the later stages, the more common deficiencies that you might see might be related to particular nutrients like iron or B12 deficiency leading to an anemia. If there's purging going on, you can see hypokalemia, you can see other electrolyte abnormalities as a result of that. And then often in patients with binge eating disorder, we do often see metabolic disturbances like elevated glucose, elevated lipids. In all of the eating disorders, you can see abnormal liver function tests. It can be either due to starvation or it can be due to fat deposits in the liver. And that just sort of depends on if there's more restriction or more binging. You may see some abnormal liver function tests as a result of that. But like I said, sometimes these patients have completely normal labs and they're still very sick. They still have a lot going on, but the labs can look normal.
Right, absolutely. So when we see constipation on the GI side, I try to stay on the milder side with natural things like psyllium husk, maybe Miralax, rather than going to prescription laxatives, and then encouraging them to consume the right amount of water. Fluids is something people often overlook. Do you see that these things might help people with eating disorders as well, or do you have something that works better for most of them?
Yeah, so definitely in the case of a patient who has been undergoing restriction and has a slowed metabolic rate that's causing their constipation, in the process of having them refeed, it can be difficult to have them take in enough calories orally. One, because they need such a higher amount of calories compared to someone who has not been restricting, because they have to repair and rebuild all the tissue that was lost. So they need to eat, sometimes twice the calories that someone else their age and health status would normally eat. And so it can be hard for them to get enough food in. And so we do sometimes use things like Miralax to help them feel more comfortable, to help them have bowel movements. There's also a medication called Reglan, which is a prokinetic agent that helps with nausea or early feeling full easily because the gut has slowed down so much. And so we definitely use those things. I do have caution with patients who have been abusing laxatives and things like that. Like certainly we need to manage their bowel regimen, because if they've been abusing laxatives, it can be hard to get the gut functioning back to normal. But obviously you want to be cautious that you're making sure that they're getting the support they need elsewhere to not abuse those medications and have difficulty with using them excessively. But Miralax is a really common one that we use. The fiber can be difficult because if they're having already early satiety, the bulking can be difficult. And so a lot of times in the early phases of refeeding, it's going to be like less fiber dense, more calorically dense foods. And then later, as things are improving, the fiber can be added back in. But Miralax is a really commonly used one for sure.
How about probiotics? Do you tend to use, is there any role for probiotics?
Not to my, in terms of evidence-wise, not to my knowledge. I'm sure there are studies on it that I'm not aware of. And I'm sure, especially with all the research going into like the gut microbiome and the mind-gut connection, all these things, I'm sure that's something that will come up. I haven't really seen a role for it. I think generally when I'm concerned about adding a probiotic, I usually get GI involved because I don't want to use them inappropriately. And, there's so many things being marketed to patients in terms of probiotics being a panacea for all things wrong. And a lot of that marketing is very steeped in diet culture and in the weight loss industries. And so I try to avoid those things as much as possible, unless there's a really compelling indication from GI that it would be beneficial to a patient.
Absolutely. And so for those people with heartburn or acid reflux, and do you sometimes see like spontaneous regurgitation in these purging subset of patients? And does that eventually,
Yeah.
sometimes it becomes a habitual thing without realizing they just bring up and they don't want to do that, but they do. Do you see that sometimes?
Yeah, that can be, and it's not something that in my role I've seen a whole lot of, I have to say, but I, in my reading and studying on this topic, it certainly is something that can happen. The patients that I tend to see, most of the time they're not having so much regurgitation, but they are having a lot of heartburn and reflux and have a really hard time during both the refeeding process and then even afterwards, once they are weight restored and once they are, doing much better from a nutritional standpoint, sometimes the reflux does persist. And so, we manage that with PPIs or H2 blockers, similarly that we would in anyone else. And usually that works well.
Yeah. So do you then use the help of a nutritionist or a dietitian ongoing to help them slowly get back to their normal calorie intake?
Yeah, so definitely any patient that's had an eating disorder needs a multidisciplinary team as part of the recovery. And so that's going to include a dietitian and it's going to include a therapist at a minimum usually. Ideally these are a therapist and a dietitian that have additional training and experience in eating disorders, because not just any dietitian and not just any therapist is going to necessarily know how to handle these conditions. Like you mentioned before, it's not something that every clinician is trained in, or has had exposure to. So ideally, a specialized therapist and dietitian to help them with, both this mental aspect and then also the nutritional aspect of the nuts and bolts of how to refeed safely and how to rebuild tissues that were lost and all these things. And then a medical professional who is overseeing medically how the patient is doing and able to determine the appropriate level of care for that patient, because there are patients who can safely refeed as an outpatient. Many patients who are not severely restricting don't require inpatient or partial hospitalization or residential care. But often patients who have been severely restricting do require a higher level of care for monitoring during their refeeding process, because there is a risk of refeeding syndrome. And so, having that medical professional to make that determination about the appropriate level of care and then monitoring them appropriately during the process.
Absolutely. Can you elaborate or point any resources that these patients could use during the treatment, even after the treatment, and what they might be?
Yeah, so a good place to start, especially for if you're someone who thinks a loved one of yours may have an eating disorder, a good place to start is the NEDA website, NEDA. It's the National Eating Disorders Association, and their website is neda.org. And they have a quiz you can take to help you determine signs of an eating disorder, both the person experiencing the symptoms or a loved one. And it often is a loved one who is noticing signs and symptoms. The patient often may not realize that there's a problem. And then they also have a helpline that can help connect you to local resources for treatment. So that's a great place to start. Their website also has tons of great information about eating disorders and the treatment and the different types and the symptoms and all of that. There's also a program called Project Heal, which is a nonprofit that provides financial resources, because unfortunately, a lot of care for eating disorders is not covered by insurance. Insurance companies do not do a very good job of providing adequate coverage for these things, because their reimbursement for the services is so low that most of the practitioners cannot afford to take insurance and provide the service. So many of the practitioners are not in network, and then those that are few and far between. So for a patient who maybe cannot afford that out-of-pocket cost or has no insurance, or is underinsured, has a high deductible plan, any of these things, the Project Heal is a great website for helping to connect you with care and then financial assistance if needed. And then a lot of cities like metro areas will have a professional organization of eating disorder specialists in that area, probably not in some of the smaller towns and cities, but certainly in the large metros, I would expect that. And so usually if you just Google your city eating disorder specialist, it'll probably pop right up. We have one in Houston called the Eating Disorder Specialists. And we have, monthly meetings with educational sessions for the practitioners. And then also, it's a resource list for patients who can look and see what therapists, dietitians, medical professionals, all of that are available.
Okay, that's awesome. That's really useful. Thank you. I really appreciate that. Since there are so few physicians like you who take care of eating disorders, do you guys do televisits by any chance if somebody wanted to reach out from out of state?
Yeah, so I'm only currently licensed with malpractice in Texas. I do have a California and a Pennsylvania license, but I don't have malpractice coverage for those states currently. That's probably maybe something that I'll change in the future, but I do feel strongly about examining these patients in person, at least at some regular interval, depending on the severity, how recently they were in treatment, all of that. Generally, I see my patients for the first time in person, and I spend about an hour and a half kind of going through their history and determining the appropriate follow-up plan. And then for a lot of patients, especially those who have recovered and are just needing ongoing care from me, a lot of times we can do their additional visits all virtual. And I just see them in person once a year. And so I do have some patients that live in other parts of Texas. Like I'm in Houston, they may live in Dallas or Austin or one of the smaller towns. So I do have those patients. And then certainly for people who live out of state, you can always come to Houston, but it is tricky because, that's quite a bit of travel for people.
Yeah, absolutely. Okay. All right, that is awesome. I mean, that's really great resources. We ran down the overview, the symptoms, and how to manage, and then most importantly, the resources too. So, thank you for sharing that. That was a great discussion, I think. And to the listeners, thank you for listening. And please post any questions in the comments. I will add those resources in the comment section too, so you can find where that is, and as well as how to reach Dr. Berens on social media as well. So thank you. Thanks again. It was a pleasure. Thank you.
Yeah, thanks so much for having me.
Absolutely. Yeah.